Hello, everyone. Thank you for joining us today. I see a lot of you coming in from the lobby. I'm going to wait just another minute or so, and we'll get it started at the top of the hour. I say this often, but I am a little uncomfortable with silence. I feel like we need some like elevator music here. All right, it is 1 o'clock. I'll go ahead and get us started today. I do see some people still in the lobby, but they can join us as they need. Hello, everyone. Welcome to the Rural Health Executive Educational Series. I am Cody Smith, and I'm the Director of Rural Partnerships at NRHA Service Corporation, and I'm thrilled to be your moderator for today's session. Before we dive in, there are a few quick things to know. This session is being recorded, and you will receive an email with the recording later today. Please feel free to share that with anyone who you think might find the information useful, helpful, and anybody that may need to rewatch it as well. At the end of the session, we do ask for your feedback through a short survey. Your input really does help me make sure these sessions are relevant and as useful as possible for you and your peers. So if you take a moment to fill that out, I truly appreciate that. Now, a couple housekeeping items. All attendees are muted. We do this just to keep things running smoothly. Presentation should last about 45 minutes. This does allow for about 15 minutes at the end for a Q&A. But if you have a question, please don't wait. Go ahead and drop it into the question section of your go-to webinar control panel as it comes to mind. This is your chance to ask our experts and get advice tailored to your needs as rural healthcare leaders. Today, we're fortunate to have two exceptional speakers with us, Shad Ritchie and Megan Hazelton. And today, they'll share the 2025 Rural Provider Compensation Survey results. So with that, I'm going to turn it over to Shad and Megan so we can get started.
All right, thank you, Cody, so much. We appreciate it. So as Cody said, my name is Shad Ritchie. I am a senior consultant with Stroudwater Associates. And my colleague is also going to be speaking today, and I'll let her introduce herself.
Thanks, Shad. And my name is Megan Hazelton. I'm a consultant with Stroudwater Associates, and we're excited to share with you all the results of our third annual Rural Provider Compensation Survey.
Yes, exactly. So first, I wanted to thank the NRHA for allowing us to present today, obviously, but then also we really want to thank both NRHA and NOSORH for their collaboration with Stroudwater to help produce this important rural provider compensation survey. This is really good data, rural specific, so we hope that everyone finds this really valuable. And as you know, with compensation survey data, there is a lot of detail that goes into this. And so we could talk for hours about the survey results, but due to the time today, we're gonna, for today's presentation, we're gonna do a high level of the results, but we are more than happy to have individual conversations with any organization about any of these survey results. But again, as Megan and Cody talked about, we are going today talk about the third annual Rural Compensation Survey based on provider responses. And then this is our 2025 Stroudwater Rural Provider Compensation Survey based on 2024 data. So with that said, our agenda today is going to go over some high-level topics related to the provider compensation survey itself, just to give you a little overview of how we, what the responses were. And then we're going to talk a little bit about types of compensation. We're going to review some of the findings related to primary care and specialty care, and then go over some benefit information that we were able to glean from all of the responses, from all the great information that we were able to get from the responses. So with that said, and lastly, we'll do a Q&A session. So we're going to start with the provider compensation survey.
Yeah, so just to kind of kick us off here, so our 2025 survey was released back in the winter of 2025, so coming up on a year ago now. And we, again, collaborated with NRHA and NOSORH to push this survey live to rural hospitals across the country. All of the data reported is based on calendar year 2024. So when we're referring to the data and referring to the 2025 report, just keep in mind that it is 2024 data. We're also going to reference our 2024 report a little bit. And so again, that would be based on 2023 data. So I just want to make sure everyone's aware of that because it can be a little bit confusing. Additionally, all of our compensation data that we're going to talk about today is total cash compensation, and it's also all based off of a 1.0 FTE. And so this is our third year doing this survey in-house, and the purpose of it is to really provide insight into rural hospitals and promote more informed decisions when we're talking about physician and APP compensation. There are a lot of different surveys out there. However, we've found in our work that, you know, the industry is still lacking rural specific data. And so our goal was to go out there and just get data from rural hospitals to really get a better understanding of what the compensation market and industry is looking like specific to rural. Our respondents range from independent hospitals that reported fewer than 10 staff beds to rural system affiliated hospitals with more than 150 staff beds. And that chart there, table on the right, is really looking at our response count from 2023, 2024, and 2025 based on organization type. In addition, we also had 74% of our respondents were critical access hospital. So again, we just between the independent hospitals, rural system affiliated hospitals, and cause, we really had a lot of variation in the type of organization. Next slide, please. So again, you know, we're really focusing on total cash compensation here. You know, when individuals were reporting data, we did ask for them to report the average compensation paid within the 2024 calendar year. We did ask this by specialty as well as provider type. So we gathered data for nurse practitioners, physicians, physician assistants, CRNAs, LCSWs, really any type of provider for a specific specialty that we we were asking that data. We also asked for respondents to provide the number of providers by specialty. So we're really trying to get that total FTE count represented in this survey data. Additionally, we collected compensation data by employment status, but today's presentation, just with the amount of time that we have, we're really going to be focusing on the employee total cash compensation data. This year's survey, we had 197 responses reflecting 41 out of 50 states. And again, we were collaborating with NRHA and NOSORH, as well as a few individual state offices of rural health to help us in the promotion of this and development of the survey. One thing we do want to note is that all of the survey data reported is self-reported by organizations, and that we don't have a way of validating that. So we just want to flag that for individuals as well. Next slide.
All right. Well, as Megan just mentioned, the number of respondents that we had, based on the number of states, we had 41 out of 50 states total. And then what we do is we take the information and we can drill it down to different parts of the nation. So you'll see that when we looked at the Midwest, it accounted for 28.9% of surveys returned. And then when we looked specifically at the South region, there was a higher percentage of independent respondents, which I thought was interesting. And then with the Northeast, that region had the highest percentage of health system respondents, which I thought was interesting. So continuing a little bit with the respondent details, we had 42 respondents that indicated having over $50 million in hospital revenue. Some of you on the call, we understand that there's obviously some organizations that have higher and lower. We love to get data from all sources. So please don't not submit data based on revenue. The other component is almost 72% of respondents reported having a rural health clinic within their organization. And then finally, 64% of organizations that we were able to get information from were unsure of which Medicare fee schedule they use, which is an increase from 53% in 2024. So as many of you out there probably are compensating your providers based on productivity. Sometimes you look at visits, sometimes you look at work RVUs. And what this tells me, and Megan, you can chime in on this too, but I have a feeling that if the organization didn't know which Medicare fee schedule they were on, most likely it's because they probably are not paying based on work RVUs. What are your thoughts on that?
Yeah, I agree, Shad. I think every year this is probably the most shocking data point that we get. It's just the number of organizations that, aren't really sure which physician fee schedule they're using. And, in some instances, it might be the individual filling out the survey. Other instances, it really might be that they're using outdated fee schedules. We've certainly run into that as well. So yeah, it continues to be an interesting data point. And yeah, it is really important to understand this, especially if you are paying a productivity incentive, particularly if it's work RVUs.
Yeah, and the last point there says no respondents reported using the most recent fee schedule at the time of the survey. And obviously, when we work with rural organizations across the nation, we highly recommend using the most current CMS fee schedule for work RVUs, unless there's a major change to work RVUs. That happened in the COVID period, as a lot of us know. There was a significant change in work RVU values. But heading into 2026, there are a few slight changes to work RVU values, and so be aware of that, and we will be reporting on that as well in future presentations. And then finally, the majority of the respondents without an RHC do not have a patient-facing hour requirement for APPs or physicians. And I found that very interesting. But then the second bullet there too, it says in RHCs, 37% do not require patient-facing hours and 21% require greater than 36 hours. So we know in 2025, there was a change in the RHCs where there was a removal of the visit requirements. So there may be some reason why organizations are not focused on patient-facing hours, but we highly recommend that organizations set that expectation for the number of patient-facing hours. One, because it's going to allow the providers to understand how much they need to have face-to-face with patients. It's going to allow you as administrators to be able to help with your financial performance. But then the other thing that we're seeing across the nation too is that when you recruit new providers to the organization, we're seeing a lot more providers wanting more flexibility. So that's going to change. And what we see is that every time a new provider comes on board, there could be a different type of negotiation with that one individual. There needs to be some consistency. And so we highly recommend that everyone identify what is a 1.0 FTE within your organization and have that description so that everybody knows what that is, especially when you're having benchmark data like we're talking about. All the benchmark data is based on a 1.0 FTE. So if someone is less than a 1.0, we have to adjust for that factor. All right, so types of compensation.
Yeah, so here we're going to start diving into some of the compensation types that we are seeing based on the survey results. So In this year's survey data, it's really showing that, almost 44% of respondents are paying providers entirely a straight salary with nothing tied to performance or quality. In 2024, it was closer to 55% of organizations were paying a straight salary. So that is showing that, the industry, the rural industry is starting to move more away from just a straight base salary, more towards incorporating some of those incentive models within their organization's compensation structure. And so 34% of our respondents provided some form of incentive compensation. 32.5% were providing a productivity incentive. So, that could be a work RVU based or visit based. We have a list here on the side here, patient panel size, percent of collections. We typically see work RVU based being the most, prominent in the industry, but certainly all of these others are also types of productivity compensation. When it comes to quality incentives, we're also seeing, rural move more towards implementing more quality incentives. So our data is showing that 22.8% of independent hospitals are providing quality incentives, which is an increase from 16.7% in 2024 report. And nearly 13% of health systems are providing quality incentives, which is also an increase from the 2024 report. So I think the data is definitely mirroring what Shad and I are seeing in the industry when we're working with organizations and starting to implement more productivity and incentive models, as well as those quality incentives.
Yeah, thanks, Megan. Some additional types of compensation that many of the organizations that are listening to this now, or whether on the recording, most of the organizations that we work with, and obviously through the survey, we see for physicians, student loan repayment. And the average student loan repayment is right around $54,000, $55,000 for physicians. And then another type of compensation for physicians for recruitment and retention. And I would think the student loan is also for recruitment and retention, but sign-on bonuses as well. For physicians, the average was about $35,000 in sign-on bonus. And then lastly, for physicians, respondents said that they pay for medical directorships. And on average, that was right around $28,000 to $29,000 in annual stipends. And again, that was specifically for physicians. We then asked the same question for APPs, or advanced practice providers. And most organizations are also paying the same to APPs. Student loan repayments in the amount of about $40,000 in loan repayments. And then for sign-on bonuses, we do see that a little bit lower for APPs in the amount of $18,000 to $19,000 in bonuses. And then finally, we do see APPs being medical directors in their respective organizations. And that's interesting, and we know that a lot of organizations rely on APPs because they make up a large majority of your providers in rural communities. So, and some of the APPs are actually more productive than physicians. So I think that's why APPs are in that medical director role, and we're seeing them at about $24,000 to $25,000 in stipends. The other things that I wanted to add to, and Megan, you can chime in on this too, but on the loan repayment, obviously organizations can pay that and count that towards total cash compensation, but also it's really advantageous for organizations to look what's available in your state to see if there are any state grants that allow for loan repayments.
Yeah, so in addition to, just getting a better understanding of types of compensation in terms of base salary, productivity, and any other sort of incentive-based model, we also looked into what are the other types of incentives here, looking at sick time, vacation time, retention bonus, all of that. So this slide here is focusing on physicians, and the table is broken out based off of independent respondents and health system respondents. And when it comes to physicians, we're really seeing that vacation time payout, production incentive, sign-on bonus, and medical directorships are really the most common types of additional incentives and compensation for physicians. I also think that just generally we are seeing an increase in the quality incentives and really even good citizenship in the work that we're doing. But I don't think the most common types are necessarily surprising to us. And Shad, I don't know if you have anything to add there.
No, I do think that this is common in a lot of places. I do think, slowly organizations are going to quality. It's hard sometimes to get that data, clean data out of your EHR systems. So that's probably why it's starting now. EHR systems are evolving.
Yeah. And this slide here is looking at it specific to APPs. So again, really the same type of compensation buckets are the most common. Again, seeing an increase in quality incentives within the market. You will see that the administrative stipend is a little bit less common among APPs. That was a higher percentage of respondents provide admin stipends for physicians. But again, I don't necessarily think that any of the data here specific to APPs or physicians or between the two is surprising to us in what we're seeing.
Great. Yeah, I think this is good information to have between both physicians and APPs included in our survey. So that's good information. The other component we've already talked a little bit about is medical directorships. And obviously for a lot of organizations, we and the survey data actually helps with this as well, but far more medical directorships are provided by physicians rather than APPs, which is consistent with overall industry observations. The median medical directorship compensation for physicians was about $25,000. We did have a report from an organization that paid a medical director stipend of up to a little over $100,000 for that particular year. For APPs who are actually working in the role of a medical directorship, we're seeing the average of about $17,000, $18,000 for APPs. We did have one organization that reported a maximum stipend of about $60,000 for their medical director leadership.
Yeah, and Shad, I just want to point out, just want to point out here too that when we're doing this medical directorship analysis, this is not broken out by provider specialty. So if you were to compare this physician median percentile compensation of $25,000 to, let's say the family medicine physician median annual stipend in the MGMA national survey, the median for MGMA is also $25,000. So I think when it comes to, it's an important caveat to make with this data too, of that, certain specialties are going to have a higher stipend, certain roles and responsibilities as well.
Yeah, no, that's good information, and it's good to know. And we do look at MGMA, AMGA, and obviously our information as well. But it's good to see that there's some sort of standard across the organizations within the nation. Anything else, Megan, from your perspective so far?
Nope.
Okay, perfect. So what we wanted to do next is review some of the findings for primary care. And most organizations that we work with Obviously, there's internal medicine. Sometimes OBGYN can be factored in as primary care. We do a lot with family medicine with OB and without OB. So what we thought we would do today is focus on family medicine with and without OB, but obviously other specialties are going to be in the report. And if you participated in the report, you'll get more data as well. But interestingly, for family medicine with OB, the median compensation increased just slightly between the 2024 report and 2025. So in 2024, the median total compensation for family medicine with OB is about $322,000. And now in the 2025 report is $343,000. That's about a $21,000 difference or an increase. And then for family medicine with OB, the gap between organizations with RHCs and those without has also narrowed. So in the 2024 report, the difference in median compensation for this group was nearly $100,000. So the difference between with and without OB was about $100,000. But in the 2025 report, it is now about $40,000 difference, which is much lower in the gap. The next item is family medicine without OB median compensation. Again, total compensation is around $275,000 is what we're seeing. And then when comparing organizations without RHCs to one another, providers with OB have a median compensation of approximately $380,000, while those without OB have a median compensation of about $264,000. We are seeing more organizations utilize family medicine with OB, particularly those that have extra training with C-sections, and because of the lack of OBGYNs that are available. So we are seeing that more rural organizations are using family medicine OB with C-section training. And then continuing a little bit more on primary care physicians, compensation for both family medicine physicians with and without OB both increased, and that is no surprise. We feel obviously primary care in a lot of rural areas have to do more complex work. There's limited specialties, but the increase was between 6% and 4% respectively between the 2024 and 2025 report.
So we collected family medicine data as well for advanced practice providers. We were looking at it, collecting the data both for nurse practitioners and PAs, as well as for both those that work with obstetrics and without obstetrics. And so one thing that was interesting was that, family medicine NPs are continuing to earn less than $135,000 per year, regardless of whether or not they have OB responsibilities. Which compares relatively the same if you're looking at MGMA median data for both nurse practitioners, family medicine with and without OB. It's 135,000 is pretty much in line with that MGMA median data as well. However, in this year's data, we did see some shifts happen. And so one thing that was interesting was that nurse practitioners without OB actually reported a higher median compensation than those with OB. So it's a little bit inverse from what we were seeing when it came to the physicians. And then among nurse practitioners with OB, compensation at the lower end really declined, while compensation at the 90th percentile increased by 59%. And so that gap between that compensation gap really widened. And then when we were looking specifically at RHC settings, reported compensation for nurse practitioners with OB had a really wide range from $80,000 at the low end to a high of over $300,000, which again was showing that there's a really big pay gap existing within the single role across the country. And there's a lot of things that factor into that. You know, is it a newer grad? Is it a more experienced NP? You know, is the market difficult to recruit for? You know, are you trying to retain your providers? There are a lot of variables that factor into that as well that this data does not collect, unfortunately. And then again, we also looked at data for physician assistants. PAs are continuing to outpace NPs in both OB and non-OB roles. Again, just showing that there continues to be a pay differential across APPs. Next slide. And then we looked at this data as well for, you know, practice. Is it a full practice state? Is it a restricted practice state or reduced practice state? And the reason we like to look at this is because it's interesting to understand how, you know, practice regulations impact compensation for physicians who are having to supervise APPs. Or APPs who are able to practice at the top of their license. This year's data does show that full practice states are actually paying less than restricted or reduced practice states, except for the specialty of NPs without OB. Those nurse practitioners who are practicing OB as well are making more than triple the amount in restricted practice states than in full practice states. And I think this data is maybe a little bit opposite of what you would think it would be. But, you know, as we are kind of thinking through, you know, the possibilities for this and what these markets look like in reduced and restricted practice states, you know, one possibility is that, you know, the APP supply is going to be a little bit lower in reduced practice states because, you know, APPs are going to school, they're spending a lot of time on education, and they want to be able to practice at the top of their license. And so, you know, there's often lower supply in these states with more restricted regulations, which can oftentimes mean higher compensation. Lower supply, more competition is going to increase the compensation in those states.
Yeah, that's really interesting, isn't it, Megan? All right. Anything else, Megan, from your perspective?
Nope.
All right. So a lot of good information on primary care. Obviously, there's definitely more data out there in the report that we have available. Some of the things we also wanted to do today was review some of the findings specifically on specialty care. And we're going to start with one of the specialties that we hear quite a lot about in our work across the nation, anesthesiology, which includes CRNAs. So rural areas tend to rely heavily on CRNAs for providing anesthesiology services, as you all know that are on the call. CRNA compensation for this survey ranged between $200,000 to nearly $400,000. As we know, over the course of the last several years, we've seen compensation rise in CRNAs. Physician anesthesiology compensation ranged between $290,000 per year to just over $700,000 in total compensation. So overall, anesthesiology and CRNA median compensation increased 14% and 11% respectively between the two reports, the 2024 and 2025 reports. Any other comment about that, Megan? Do you think, in your opinion, we're going to see CRNA compensation still go in this trajectory?
Yeah, I mean, I think it's going to continue to rise, but I do think maybe at a slower rate. I think, you know, we're still seeing an ongoing workforce shortage that's certainly contributing to this as well. You know, I also think just an important thing to note with these compensation, right, is, you know, you have to, this isn't factoring in, or sorry, this isn't delineating which respondents are, have call, which respondents don't have call. So I think that is also playing into and kind of showing this wide range of compensation data when we're talking about CRNAs and anesthesiologists. I think in our next year's report, we are going to be gathering a little bit more information on call coverage and call rotation. We're going to be able to better identify, which of this data here is specific to straight salary, which of it is more contributed to call coverage and call rotation as well. So I think this continues to be a really interesting data point, and I'm just looking forward to next year being able to kind of drill down a little bit more to better understand each factor of this compensation.
Yeah, totally agree. Some of the other specialties, so the next slide is a little bit busy, and I apologize for that. What this slide is basically hoping to show is that there has been some decreases based on the report from between 2024 for some specialties, if you're an MD, if you're a PA or an NP. So it's interesting to see some of the decreases versus those that either have stayed consistent or may have increased. So Megan, when I was looking at it, I noticed on the physician side, cardiology, neurology, OBGYN, which I was surprised about, and radiology all had decreases from the 2024 report to 2025 report for the total compensation.
Yeah, and I was surprised by the decrease in OBGYN, but I was also really surprised by the dollar amount of these decreases. I mean, you're talking about $100,000 from cardiology, $200,000 in radiology, another $100,000 plus in neurology. I mean, those are drastic changes in the compensation amounts. And then I had to just compare this to MGMA and kind of seeing what they were seeing there. But, a lot of the specialties here where we were seeing increases in the median compensation, there were also increases in median compensation when you're comparing the MGMA 2025 and 2024 reports. And then, a lot of these median compensations, are fairly in line with what, some of the other survey data reports are seeing out there as well.
Yeah, and when I look at PAs and NPs, I didn't see the variance as high as I did on the physician side, like you were just talking about, some $100,000. The PAs and NPs, if compensation went down, it was not as drastic. I don't know if you use that.
Yeah, I agree. And I think too, I'm not necessarily surprised by the increases either we're seeing in compensation when you're talking about physicians or PAs or NPs, but there are also, just like there were some, specialties here in the physician category that decreased a significant amount. I mean, there are also some specialties that really increased, right? We're seeing orthopedics, a $100,000 increase, and urology, $145,000 increase. And so I think those increases are also really interesting to see as well.
Yeah, and the other thing that we're seeing a lot too across the country, some of these type of specialties, if they're not specifically available in the community, a lot of times they may outsource that to maybe have a provider in one of these specialties come in 1 to 2 times a month. So they're paying a little bit higher rate per day or per visit for when they come. So I'm not sure if any of that has anything to do with this, but we are getting requests for fair market value assessments for these kind of specialties in markets where they wouldn't be there every day.
Yeah, that's a good point, Shad, as well.
All right, so yeah, this is really good data. Again, a lot of this is going to be in the report that is available for everyone. This is an interesting slide too, Megan.
Yeah, so we also collect data on benefits. Shad and I will go into organizations, and we always want to understand what are the most important benefits to your APPs and your physicians. I've always been shocked by, I was working with one organization and they were so set on keeping their free meals. They loved their free meals. It was, the highlight of their day. And so it's always really interesting to see this data and see which organizations are offering what and seeing the change over from year to year as well. I think the most common benefits we were seeing in both physicians and APPs weren't necessarily shocking. You have your retirement plan, health insurance, CME, vacation time, and all of that. I think what was interesting is that in some of these organizations that responded, they might be giving physicians one benefit, but then not be giving APPs the same benefit. And so I think that's one thing that's interesting when it comes to, a pay equity standpoint as well. We certainly deal with that, that same organization that loved their free meals. Not all of the APPs had access to that as well. So wanting to always take a look at what benefits your organization is offering and being able to, understand where there may be gaps in pay equity or where you can kind of streamline some of these benefits. And also just really understanding what's important to your providers and making sure you're offering benefits that, really mean a lot to them.
Yeah, that last point I totally agree with, because that's going to help recruit and retain providers. Some people are not financially motivated. I haven't seen many, but there are some that are not financially motivated, but they would rather have some of these benefits versus, productivity bonus. So yeah, that's a good point. All right, so that concludes our overview of the survey, but Megan's going to talk a little bit about what's next for 2026.
Yeah, so just a few things to wrap up before we get into what's next for 2026. I do just want to reiterate that we do have a report that is downloadable on our website that does share more information with you all. It's a really great report, a lot of great detail in there that's going to just give you a little bit more meat to what we were able to present today. So I really recommend you all looking at that. And if you have any questions that you want to take offline or, any suggestions you have for us, also please let us know. We will be continuing to distribute the survey annually. Our next year survey that's going to launch in mid-January is going to be a new and improved survey, I like to say. We will be starting to collect productivity information, which we have not done. So just how we collect the average total cash compensation for specialties and provider types, we're going to be collecting that same data for productivity, and we'll be able to share next year, the median and percentile ranges for productivity. Since it will also be another year of total cash compensation survey data we'll be collecting and having a percentile data for, we're also going to be able to, trend that compensation data forward. So when we're releasing our 2026 report that's based off of 2025 data, we're actually going to be able to project that compensation data forward so that we can also show you what that 2026 data is going to be looking like. Today's presentation did focus on median data. Our publicly facing report is also median data. If you participate in our survey, you are going to be able to receive the full results. So 10th, 25th, 75th, and 90th percentile data in addition to the median. And that's going to be really huge next year, especially with the addition of the productivity data. So if you want to be making sure that you get our survey, the link to the survey to complete that once it goes live, please feel free to reach out to us. Our emails are on the screen here. And yeah, we appreciate your time today. And I think we have some time for Q&A. So thank you all.
Wonderful. Thank you, Megan, and thank you, Shad, for all the great information. We do have lots of questions, so I'm going to dive in. I did have a question. We have someone from Alaska that would like to take part in the survey, so I'll make sure you get the information, her information, so you can reach out. So just to go through these questions, is patient-facing time actual in the exam room with patient, or does it include the provider reviewing the chart before entering the exam room?
That's a great question. So it's actually the time that's spent with the provider, with the patient. So it's what we consider time that is physically and face-to-face with the patient. We know that there's going to be time that the provider is going to have to review the chart, and then also after the visit document. There is a standard out there that we are seeing that if you're outpatient only, a lot of organizations are giving providers 32 patient contact hours and then 8 hours of administrative time. And so what we consider face-to-face is actually being in front of the patient, but then there's got to be some time for administrative work as well to look at lab results, radiology results, and then document appropriately. Megan, I don't know if you want to chime in.
No, I think you covered it, Shad.
All right, thank you so much. So next question, what are regional differences in stipends and bonuses for clinicians?
Yeah, so we do collect the data regionally as well. So any data that we are able to actually analyze based off of the number of responses is going to be in that full downloadable report on our website that I mentioned. So anything that's not in there, you can always feel free to reach out to us to get a little bit more information. Sometimes we don't necessarily include it in the large report just because the response count is low. So we might feel like it's not, statistically significant enough to present in a report or on a presentation. However, that doesn't mean that we don't have the data and that we're not willing to or happy to share that information with you.
Thank you so much, Megan. Another question, and I believe this is talking about, this is from Rebecca, I believe it's talking about the student loan compensation portion. So it says, is this annually specifically for student loans?
So,
and Rebecca, oh, I'm sorry, Shad, go ahead.
Well, go ahead, Cody. I don't know if there's anything that she wants to add to that.
Yeah, I was just gonna say, Rebecca, if there's more you want to add to that question, you can go ahead and shoot it into the question panel and I'll expand.
A lot of times what we see with student loan repayment is, when they negotiate the initial contract, they will negotiate, their sign-on bonus and then also student loan repayment. And those amounts usually are tied to a period of time for them to be employed with the organization. So normally we see, if you give X amount of money for both of those things, then it's a 3 to 5 year commitment for those providers to stay at that organization. If they leave before those terms, then they have to pay a prorated portion back. But what we normally see is that it's paid up front, and then when we do the benchmarking, though, we divide it by the number of years that they have to stay at the organization. So, for instance, say if it's $100,000 and they have to stay 4 years, then it's $25,000 per year when we analyze fair market value as part of that total compensation.
Yeah, Shad, that's a great point. I think the key there is that, your student loan repayments, what you're paying to that provider, or even if it's the institution, that should be calculated and included in your total cash compensation. So I think what's important in looking at this data is that it's not necessarily, it is the amount that's important, but it's also understanding the entire compensation package. And like Shad said, ensuring that is still, the full package is within fair market value.
Thank you. And Rebecca did respond. She said, thank you. I was wondering if the 54,708 is per year, and if yes, for how many years, or if it's a one-time. So
yeah.
All right, wonderful. Thank you for that. All right, question from Blake. Is there a distinction available to show if the family docs without OB are doing inpatient and outpatient work or strictly outpatient?
So in our, and Megan, you can chime in on this too, but in our experience, those that are doing OB work obviously are doing inpatient and outpatient because they want to do those deliveries, or if they're C-section trained, then they want to be able to perform those. So in our experience, most of those providers are doing inpatient, outpatient.
Yeah, I would agree with that.
Blake just sent a follow-up to that. It says without OB. I'm sorry.
Without OB, so we see it both ways across the nation, and this is something, Megan, you might can verify this for the survey data. Do we ask if it's strictly outpatient and inpatient?
Yeah, so we do not. So the survey data is really just essentially asking, we're not asking the details on, what your provider, if they're working inpatient, outpatient, what that breakdown looks like. Our concern with asking all those questions is we don't want it to turn into a very time-consuming survey to complete. So we do recognize that that's also another limitation. So when people are reporting the data, they are just reporting the average total cash compensation for any of their physicians or APPs that they would categorize under that specialty.
Yeah, and I would say based on the organization, they'll have family medicine physicians either work outpatient only. We've seen family medicine physicians do shifts in the ED as well as shifts in the hospital as well to be a hospitalist. So there's all kinds of variations which could complicate the people doing the survey, like Megan just indicated.
Great, thank you so much. And I believe we've touched on this, but just want to make sure I throw it out there. Does total comp include benefit package?
Can you repeat that one more time?
Yeah, does total compensation include benefit package?
No. When we look at total cash comp, it's what would be on your person's W-2. Unless, and so what we do, we say there is a caveat, unless there's a really high benefit that shouldn't be considered as part of a benefit plan. For instance, what if an organization gave a much higher match on a 401k plan, then you would want to count that towards their total cash comp. But in our survey, we did not put benefits into that.
Thank you. Does CRNA comp include only employed CRNAs or also group contracted rates and or 1099?
Yeah, that's a really good question. So the data that we were showing for CRNAs, and I'm just going to pull up the slide on my end. So we were looking at all of the data here reported is employed compensation. So again, if you kind of, we have it also broken out, I believe, by locums, contracted, all of that in our report. But for the purpose of today's presentation, we're really focused on employed. So yeah, you can see there, yeah, it's a bit really big, range in compensation that we are seeing. But that's why we also wanted to call out, right, that, maybe a provider, an anesthesiologist that's getting $700,000, right? We don't understand what their call rotation is, or their call coverage or call burden or anything like that that might be impacting that compensation amount. So it is just important to remember that caveat as well.
Thank you so much, Megan. How are regional differences skewing median data?
Yeah, so I think that goes back to, we do have the regional data. And again, it kind of is what I answered with that earlier question, or that other question earlier, is that, in some instances, we can't necessarily report the region-specific data just because of the number of responses. It might not be statistically significant. But we do have that data. And so if you are interested in understanding a little bit more about where your organization might fall compared to others who responded in your region, we do have that. We're happy to look at it and just send you, some of what that the limitations to that data would be as well.
Thank you. Is there any indication that physicians are looking more towards rural areas in general, as cost of living and work demands in urban areas seem to be ever increasing?
And I can chime in, and Megan, feel free. But in every organization that we have worked with, which is strictly rural, there is always, it's very difficult to recruit providers of any specialty, specifically primary care. And what we see is a high turnover. So I'm not sure if I'm answering the question correctly, but that's why we highly recommend that a true compensation strategy is really put in place so that it can retain and recruit providers to your organization. There are those that are in med school and they have these grandiose ideas that they really want to work in rural, and then they get there and they realize, oh my goodness, I have to take care of that major complex patient, and I can't send them to pulmonology, or I can't send them to urology right down the street. So we're seeing that it's hard to recruit in all rural communities right now.
Yeah, I would agree with that, Shad. We just really continue to see that retention can be a challenge in rural, and just, getting your providers there, right? You have to, and a lot of times when you're recruiting a provider, you're recruiting their whole family, right? You have to make sure that, their family's also going to be happy if they have one moving with them. So we're definitely still seeing recruitment being a challenge with a lot of the organizations we're working with. And that can sometimes also lend itself to there being higher compensation amounts when you're comparing it to national data as well.
Wonderful, thank you. We do have another question about distributing the surveys, so if you just want to reinforce that at the end, I'll come back to it. I want to make sure we get to this question. Is there any way to break out the provider total comp into each contributing factor for the overall number, like base student loans?
So not with the data that we collect. So we collect total cash compensation. We're not collecting base salary or productivity or anything like that. I do think what will be interesting with next year's iteration is that we will have a better understanding of what's contributing to some of this compensation. We will be collecting productivity data and understanding whether or not organizations, provide a productivity incentive. So we'll be able to glean a little bit more using that data. And then we'll also be asking more details on call rotation, call coverage, call burden, and all of that to also gain better insight into how call compensation might be, contributing to higher compensation amounts as well. But as the current data currently stands, we do not have the ability to break it out by certain compensation buckets.
Yeah, I'll just add, Cody, we would love for anybody that's seeing this or seeing this via recording to email us things that they would love to see in our survey in the future, because that's just going to allow us to get even stronger with the data that we produce.
Thank you so much, Chad and Megan, for all the information and questions. I just want to take this time to hand it back to you to reinforce a couple things on how people can receive the survey, so how you distribute it, if somebody wants to participate. And then I did have a couple requests for slides. So anybody who was asking for those slides, I'll make sure to get those requests to the team for you so that they can be in touch with that, and we will be sending out the recording. So Chad, Megan, I'm going to turn it back to you for any closing remarks.
Yeah, that's great, Cody. And we can also, on the slides that you sent out, we can add, the direct link to the downloadable site for our report. It's completely free to download. It's on our website, but we'll just make sure everyone here today has access to that. And then, of course, if you're interested in participating in next year's survey, you will get, the full percentile ranges of data. So if you do want to participate, please feel free to email Shad or myself, and we can make sure you get on the list of folks who will receive the email to complete the survey.
All right, thank you so much and for all the information. Thank you everyone for joining us today. I do hope this session gave you some new insights that you can take back to your organization. And as a reminder, the session recording will be sent later today, so you can revisit anything you found helpful. Before we go, don't forget, we would love to hear from you. Please complete that survey at the end. I really do use that to keep these sessions relevant and impactful. And if you're looking for additional ways to grow your leadership skills or expand your team's impact, please visit NRHASC.com for more educational resources. Also, thank you to Stroudwater for all the information today and being a platinum and founding partner with NRHA Service Corporation. We wouldn't be able to do things like this in our conferences without you.
Well, yes, thank you so much.
Everyone have a wonderful day. We'll talk to you soon. Stay safe and warm.
Take care.